strong. It's actually
Yeah, he said it was the
annoying.
break room.
Yeah. So so obviously this is still not working, and your number is still going up.
Right.
Okay. Your white cell count is 150
5.
today. Yes. And you still have those blasts. The first medication, the Jakafi, actually worked for a while, interestingly, but then stopped working, and this one has not worked at all for us. Plus, it gave you some side effect too, the nausea and everything.
But I've been taking Compazine. That worked.
That works, yeah. So that's
That
good,
works,
but
yeah.
obviously the medication itself, it doesn't
Right.
seem as it's doing the trick because the numbers are keep going up each time we see each other. Classically, I have to put you in the hospital, give you chemotherapy, and give you additional cells. Okay, and that's obviously a very toxic approach because you've already gone through that. Okay, so your body has already been beaten up with all of those, and now we're gonna give you again. So you're not the same, don't have the same strength that you had before all of this. Okay, obviously the hip fracture was a big deal as well, and that didn't help with the situation either.
No.
The other option is just doing nothing, okay, and just give you, you know, some hydria, control your counts, on and off transfusions as needed, and that's about it. And that can be done over in Oregon as well. We can also look at the clinical trials, the drugs that are not conventional, they're not FDA approved, but may be promising in these situations, and we do have them. So again, that's another options to keep you out of the hospital and not giving you high dose chemotherapy, not making you sick, and see if those working. And then it's combination of all above. We can try, for example, the drugs as an outpatient in the clinical trials. And if that doesn't work, we can try the chemotherapy, or if it doesn't work, you want to try nothing, that's okay with me as well. The chemotherapy does work, okay? So there is probably about a 50% chance that it will control your disease, okay? And then additional cells will bring your counts back faster, so that will also help. The question again is the long term, and whether your disease will come back again after that or not. So I have no doubt I'll give you chemotherapy, your count's going to be all, you know, going down, all the way down, and it will control your disease. And then when we give additional cells from your donor, that will bring normal blood counts, you know, very similar to the situation you had before. But is there a possibility that your disease come back again? Yes. When? I don't know. Is there a possibility that cures you? Yes. But that possibility is not huge now. It's probably about 20 to 30%. Okay. Versus, you know, about 50, 60% before to say, okay, it's going to cure you. So that's where we are. I just want to make sure we have all the options here, and we can discuss that one by one.
You want to try that other clinical trial?
I'm happy to do that.
Okay.
I'm happy to do that.
In the
Because
meantime,
again,
I'm still okay.
yeah, and again, you are, I mean, the good thing is that I think, you know, going through the physical therapy, you're getting stronger. So this, you know, the longer we can drag this and not giving you something that will affect your activity, I'm hoping you get stronger and stronger as we go. Okay, your activity is better, you're getting stronger, and then we can try the, you know, if you're not successful, then we can try the chemotherapy when you're stronger. So I'm happy to do that. This is a phase 1 trials. That means this we're just trying it on different bunch of leukemias and see what the response is with that. It's oral. It's just one pill every other day. Okay, so it's a simple thing to take. And the cultures, it worked really well in leukemia. So even low dose of that, it worked. Okay, but we don't know how it's going to work in human. Okay, and that's what they're doing in these trials. Okay, but at least it's something benign, and you know, it's not chemotherapy at all. So it doesn't have the side effect of chemotherapy. It's mostly something like that Jacophy that you're taking, but it's not the, you know, it's again, it's a pill. It's easier to take.
And I still take the hydroxy, whatever it's called.
And I think we may even have to go up on hydria to temporarily to control that. What they need for this trial, they need an eye exam, okay, and then they can start that. So it may take a few days for us to get everything together. And meanwhile, I do want you know to take a little more hydria to control your blood counts and doesn't let it keep going up and up again. Okay, so maybe instead of 2 pills a day you're taking now.
No, I'm taking one. Oh yeah, 2. One,
okay,
one
in the morning, one in the afternoon.
Right,
maybe instead of doing that, maybe do it 3 times a day, or you're doing it 2 in the morning, 1 in the afternoon. Just give it a little bit more.
4 times.
Yeah, just give it a little bit more so you can again kind of like temper this a little bit until we start the other medication and see if that works. And if that doesn't work, we still have that option of the chemotherapy, which again I think it's going to be. I mean, there is a good chance it works, but again, the long term, that's something I don't know.
Right.
And then obviously it's a toxic treatment, so how much your body can tolerate it, that's a big deal. That's why I'm kind of like hesitant to jump. So that's what you should do. Okay? I'm hesitant to say that.
But that's an option, so.
That's definitely an option. That's definitely an option, and definitely an option that we know it gonna, there's a good chance it works. The toxicities, how your body can tolerate that, and then what's the long term, if your disease is going to come back or not. Those are the unknown here.
Do you need more cells from my sister?
No, I think we have.
You got 2.
We have 2. That's good enough.
Oh, that's good enough.
1 is good enough.
Oh, okay.
So 2 is definitely good enough to do that, to recover your bone marrow quickly. Okay. So if I give you the chemo, it's going to be 4 or 5 days of chemo. And then we give you cells a few days after that, and it will take about 12 days, 10 to 12 days for your counts recovers.
Okay, so
that's a chemo part, okay? But again, I think we're on the same page. The further we can drag this, so you get stronger, I think the better.
Oh, that's okay.
Because you have improved, comparing with a month ago, you have a substantial improvement here, okay?
Right.
You're definitely stronger, I would think. So if we can drag it a little bit further, I'm happy to do that.
So the clinical trial could work.
Could.
And
crapshoot.
so just wait and see what happens and go from there.
Yeah, so we'll start you, and if your numbers keep going up on the drug, obviously it's not working well. We know that. If your numbers are stable, even if it's not going down but stable, then we encourage to continue and see, okay, maybe over time it will get better. But in the first week or 2, if your numbers, like the same thing you tried, the pill, if your numbers keep going up on that, we know it's not going to work over time.
Right. Okay. The second pill you had me to take was 2 weeks yesterday.
Yes.
That I would have had it. Right.
Yeah.
Now that first pill felt good. It gave me energy and whatever, but it didn't do what it was supposed to do.
And it did actually work at the beginning very well. I was very happy, but unfortunately.
What makes it not work all of a sudden? My body does something?
No, you have these what we call clones. So these cells, the leukemia cells, they're not the same. Okay, one cell has one marker, the other cell has other markers, other markers. Okay, the drug may work well in this group, but then these 2 that are not covered, then they start growing and make more of a different clone. And that's the problem.
That's not good. No.
So the drug worked on a majority of these because your numbers came down from like 150 without the hydria, just came down, or with the low dose hydria came down all the way to like 20, 30 if I remember.
Right.
So something definitely worked, but then I think other clones start to take off and cause the problem. And that's why the future we're thinking about, combining the things together to cover these clones and all of those. But those are all research, and we're not there yet, unfortunately.
Right.
Unfortunately, this is the chemotherapy, kills all of them, at least temporarily. But then they become resistant to chemo. It's like a bacteria become resistant to antibiotics. That's why they come back. But these targeted drugs, like the one you're getting, they're really targeted to certain gene problems there. and it really works very well if that's the only problem there. But sometimes there are other genes there that start taking off and cause trouble. Okay. So, have you met Kelly?
Have I met Kelly?
Kelly Jones?
I don't think so. We
No.
met Kelly. No.
Okay, so Kelly is one of our coordinators. So she's a trial coordinator. So I'm gonna ask her to bring the consent form. So you can at least look at that, look at the drugs, side effects, all of those, and just educate yourself. We're trying to find out if you need additional testing. We know for sure you will need an eye exam for that
Okay.
drug.
And why is that?
Because some of these drugs, you know, there is a chance, for example, has an eye problems, okay?
Oh, okay.
And I want to make sure if you start that, you don't have an eye problem and says, you know, this caused that. If you had something before, this is not the reason, obviously. So they just want to check that.
Okay. Because my eyes are my vision is still blurry to a certain degree.
Sure. So it's a good time actually to see an eye doctor as well. So the study will pay for that, and we just get you an eye doctor to see right away, probably tomorrow. And if that's, you know, if they say it's clear, you know, there's no major problem with your eyes. Yes, you know, all of us have problem with the eyes, but
Right.
if there's no major problem with the eyes, then we can start. The other thing that we may need to do is repeating a bone marrow biopsy. I'm trying to avoid that if possible. So I'm asking the study monitoring to just, you know, call us and say, you know, we know what you have, so why we should do the biopsy again.
How did you determine this drug is the one that you're going to use in the clinical trial?
So we look at the list of our clinical trials and see first which drugs are for AMLs, and then which ones you're eligible for. Some of the trials we have is for people who have very first diagnosed with AMLs. Okay, patients who are not eligible for chemo, like, you know, there's a 89 years old that cannot get chemo, period. So we have to look at the clinical trials, see if we have something for them. And then, so you're already relapsing and you're after the transplant. So many trials rule, you know, you're not eligible for that because, you know, they're for first line or they don't like the patients after transplant. So we put those aside and we look at the ones that you're eligible for. You're eligible for these trials, even though you had a transplant. All of those, you're okay with that. Okay.
Where do these drugs come from?
Pharmaceutical companies.
The manufacturers, what
Correct.
you're trying to see if they
So
work.
manufacturers, you know, they do extensive what we call preclinical work. That's number one. They look at the drug and say, okay, you know, it looks like it's effective in myeloma and leukemia and so on and so forth. Then they test it on normal, it's the wrong word. Then on the, you know, basically the donors, the volunteer donors, volunteer people that they're not sick or anything, but they're volunteer to test the drug to look at the side effect and make sure it doesn't have any major side effects in that. And if that's clear, then FDA allow them to try it in their patients. And that's why we try the patients and see, you know, if you're responding to that or not. There are some other clinical trials that are very, very toxic, and again, I'm not going to use those at this stage. Because if I want to use something toxic, I want to use something that I know is working. Like, I know that chemo is going to work. So I'm looking at the things that are easier, but still they look promising. It may work in this situation.
What drug is it?
It's a Hitchcock. It has basically a number name, but it's a Hitchcock inhibitor. So we're going to give you the consent form with all the information about that.
Okay.
Do you feel good about me doing this, or would you rather me go into chemo right away, or what's your take on it?
I told you I feel a little bit nervous about the chemo.
Oh,
Okay.
I see, because of my condition. Okay.
Because I want you to be more robust and stronger, and I don't think you.
Now, how am I going to do that?
You're getting better already.
Yeah.
Okay, don't you think so?
Oh yeah. I
Okay,
mean, because
so-
I'm not tired. I don't take
Yeah.
naps or anything.
Exactly, and
Right.
you're still walking with the wheelchair, I think, but with the walker, I mean.
Right.
But even that, I think sooner than later you're gonna come off of that.
Hopefully.
Yeah.
Yes.
So I think you are just getting better anyway. And these things is just to drag our feet, as I said, for you to continue to improve.
Mhm.
Okay. You're off of those, you know, immunosuppressive and all those medications, and you're getting stronger. So you are much better situation today than a few weeks ago, and for that reason, I'm happy to admit you today in the hospital at chemo. But I'm thinking maybe if I give you a little bit more time, I think that will be even better. Okay, and try something non-toxic.
But bottom line could be that I could go get more chemo unless this particular drug
Unless
works.
we see, unless we
Right.
see a dramatic response, absolutely, absolutely.
You got a lot of rabbits up your sleeve because we had 1 and 2. Now you got number 3. So
That's a little bit, that's the difference between an academic center and and a community center, because we're thinking about these things all the time. It says, what else can we do? What else can we do to be non-toxic to you and maybe helping? So we tried 2 of them, and at least one of them was working partially, but didn't work, and I'm happy to try something else. Those 2 were not on the clinical trials, okay? Those 2 were based on your genes, and we thinking about targeting that. So up to now, we have not given you any clinical trials, okay? Because I was hoping that conventional treatment, it's clinical trials, we just don't know it's going to work at all, okay?
Right.
But your chemo, your transplant, and those 2 drugs those are all conventional treatments. Those are not very experimental or off the shelf or something. Those are conventional treatment. You had a JAK2 mutation. That's okay. Let's just target that with a JAK2 mutation inhibitor. And you had another mutation. So they just try to target that with that dasatinib, Sprycel, and see if you can control that. And unfortunately, none of them work as we want. Now we are kind of like, okay, we passed the conventional treatment. They just go to clinical trials.
Okay.
Okay.
Now do I continue to take what is that one that makes me sick?
Oh, the last one.
No, you just stopped that.
I just stopped that today.
You just stopped that today. Go on a Hydrea 3 times a day.
Okay.
Okay. And we just transfuse as needed until we can start to do that. Again, Kelly's going to be here shortly. We'll see if you're, we're going to go to a checklist. I look at that just very quickly, and you're eligible, but I just want to double check 100%, make sure you're eligible, so the study allow us, to put you on the study. And if that's the case, we'll do that. If not, then we just admit you to the hospital.
We need a renewal on the prescription for the hydroxyurea.
Absolutely, absolutely.
And
I'll just do it now.
she today she got her blood count for the platelets were 26, and nurse suggested because Tuesday's the next time she's scheduled to come in, and that's
but
quite
she
a ways
probably
off.
need it sooner than that.
He thought maybe tomorrow would be better.
Yeah, I think so. I
So-
agree. I agree.
Okay.
Somebody will set that up.
I will definitely do that.
Yeah, okay.
I'll definitely do that. So where do you go for your Hydrea? Which pharmacy?
Rayleigh's in Fair Oaks.
I'm just going to put it in a few minutes. I'll get somebody here to talk to you about tomorrow.
Okay.
Okay?
Okay, yeah,
Give me
you
a few
said eye
minutes.
appointment and maybe
Yeah, let me just get
platelets.
Kelly here.
Okay.
And at least, she has to give you that
One at a time.
information, and then she can tell us what else do we need.
Okay.
Okay?
Perfect.
Give me a few minutes.
Okay,
Okay.
thank you.
Thanks.